So, hello my dear doctors. So, up to now I think everyone must be knowing about the question and answer of NEET PG 2024. But purpose of this session is basically to discuss the topics, because PYQs are not repeated much. If you see this paper, the trending is that they are more of the integrated questions they are asking, more of the conceptual question they are asking, but one thing is common: often repeated topics. They will not repeat the same statement, but they will repeat the topics. So some topics are so very important. If you see, they are coming from last 5 years, 6 years, like that. So let us start the session without further ado with the question number 1. Which receptor helps in improvement of insulin resistance in diabetes mellitus type 2 with regular exercise and physical activity? So this question is regarding glucose transporter. And if you see 5-year papers, every year 1 or 2 questions will be from glucose transporter. It can be GLUT, it can be SGLT. So we know GLUT are passive, SGLT are active. So which transporter is involved with the insulin? Insulin dependent GLUT is GLUT4. GLUT4 is the GLUT which is insulin dependent. This is very important point. And what are the point which need to be remembered from this topic? So insulin dependent glucose transporter is GLUT4. And where it is present? It is present in adipose tissue and striated muscles. But one very important point: why diabetic persons are advised to do more and more exercise? Because when they do exercise will cause increase in the expression of GLUT4. So GLUT4 expression will increase with the exercise. So either suppose there is a type 1 patient or in type 2 patient taking the insulin. So when they do exercise, the dose of insulin become less, because they will also upregulate GLUT4 expression. So this was asked in the examination. In the question, they were asked about the insulin resistance. So what is insulin resistance? Insulin resistance means that normal amount of insulin doing subnormal action. So there is no problem with the amount, but the action. Receptor is not working properly. And if you go to the biochemistry part, you must be knowing there is serine threonine phosphorylation of IRS1. Okay. Now, insulin independent transporters are GLUT1 in the RBC, brain, cornea and placenta. GLUT2 can be remembered by the mnemonic beta cell like. Beta cell, liver and intestine, kidney. Beta cell of pancreas, liver, intestine and kidney. Easily it can be remembered GLUT2 beta cell likes. GLUT3, if we see, it is like one only, brain and placenta. In brain and placenta we are having GLUT1 also and GLUT3 also. Now GLUT4 already we have discussed, it is insulin dependent. F for 5, F for fructose. So they will be in spermatocytes and GI tract. Now these all are, please remember, these all are what? Passive transporter or active? They are passive. Simple diffusion or facilitated? They all are example of facilitated diffusion. They all are example of facilitated diffusion. So facilitated diffusion is active or passive? Doctor, please remember, they are passive. Carrier is needed. When carrier proteins are needed, ATP is not needed. It is called as facilitated diffusion. In active transporter, we have SGLT1 and SGLT2. Now, SGLT1 and 2 both are present in the kidney, but in the intestine only SGLT1 is present. That is why in diabetic person we give SGLT2 blocker. What is that? All the gliflozins, canagliflozin, dapagliflozin, empagliflozins, these are SGLT2 blockers, because SGLT2 is responsible for more than 90% of glucose absorption from the kidney. More than 90%. Only 10% is absorbed from SGLT1. But in intestine, we have only SGLT1. Okay. So this is very important. Insulin receptor, insulin resistance. This topic is very important. Next point to remember in this topic is that brain prefers glucose but may use ketone bodies. Again, one of the most important point, they prefer glucose but they can use ketone bodies during starvation, but RBC utilize only glucose. They can utilize only glucose as they lack mitochondria, they don't have nucleus, for aerobic metabolism. So they use definitely the glucose. Now there is a mnemonic brick lips. So they are insulin independent glucose uptake. So what are the organ which can utilize glucose even without the presence of insulin? RBC, you can see here, B for brain, R for RBC, I for intestine, C for cornea, K for kidney, L for liver, I for islet, P for placenta, and S for spermatocytes. So they are asking in the examination, what are the organ or the tissue which can utilize glucose even without the presence of insulin? Please remember brick lips. Okay, now they can ask again, insulin act on which receptor? Because this topic is very important, that is why I am dealing in more detail. One question will definitely come in the examination regarding insulin and glucose transporter. So insulin act on which receptor? Receptor tyrosine kinase, RTK. What are the other hormones that can act on insulin receptor? One is insulin, other is all the growth factor except TGF beta. All growth factor, not the growth hormone. Growth factor means what? IGF, PDGF, NGF, nerve growth factor, endothelial drag growth factor. So all these growth factors are working on tyrosine kinase receptor, and please don't get confused with the tyrosine kinase associated receptor, JAG-STAT. Then answer will be growth hormone, leptin, and all those things I will discuss later on. So please remember, insulin is acting on tyrosine kinase receptor, and there are two different pathway of insulin. One is called as mitotic pathway, other is called as metabolic pathway. So mitotic, cell growth and development, it is called as mitotic pathway. Mitotic, it is causing cell growth and development. So it is called as mitotic pathway. So please remember, this is a mitotic pathway, and rest two functions are coming in the category of metabolic pathway. So one is mitotic pathway, other is metabolic pathway. Mitotic pathway cause cell growth and development. Metabolic pathway are important for peripheral translocation of GLUT4 in adipocyte and skeletal muscles. This is the reason glucose can get inside the muscle only in the presence of insulin or exercise. Okay, so this is about the receptor. Now how insulin is released? So whenever you take food, glucose will be there, glucose will come inside and it will generate ATP. ATP ratio will increase, it will cause influx of calcium, and calcium is going to cause exocytosis of insulin and C-peptide. So this is how insulin are released from beta cell. Sometimes they ask you which drug act on this channel. This channel is called as ATP sensitive potassium channel. Only when ATP increases, ATP-ADP ratio become more, this channel will close, potassium will increase, causes depolarization, increase calcium influx, causing what? Exocytosis of the insulin. So which drug is acting? Answer is sulfonylurea. Sulfonylurea, that is why side effect is what? Weight gain and hypoglycemia. Normally when we take the food, only then insulin is released. But if you take the drug sulfonylurea in diabetic patient, even without food, they can release the insulin. So they can cause hypoglycemia, and because of excess insulin, they can cause weight gain. Okay. Now there are some other receptor as well that can release insulin from beta cell, and that is called as incretin receptor. You know GLP-1 and GIP. It is a separate chapter. In the pharma, you will read in detail. In physiology, at least you must know they are incretin receptor. GLP-1, glucagon-like peptide, and GIP. GIP is not gastric inhibitory peptide. That was the older full form. Now it is called as glucose dependent insulinotropic peptide. Okay. So this is about this topic. I hope you will get more question in your examination. Number 2 question is gastrectomy. Patient needs supplemental. So it's very simple question, vitamin B12. But the point to be highlighted here is that if you look carefully in your past paper, 5-year paper, okay, last year there were 2 questions from vitamin B12, and there are further more questions from vitamin. So vitamin is a very important area for your exam. So you must know everything in a single page. For example, If someone asks about B12, this much come to your mind automatically in the reflex. What are the point? Number one, they are called as cobalamin. Number one point. Number two, they are cofactors for methionine synthase. It transfers methyl group as methylcobalamin and methyl malonyl coenzyme mutase. So it is a cofactor for 2 points. Number one is for methyl malonyl coenzyme mutase and other is methionine synthetase. If you remember your biochemistry, methionine is formed from homocysteine in the presence of B12. B12 is required as a cofactor, and if it is absent, homocysteine will increase, and that is not good for our heart. Homocysteine level is not good for our CVS, for the heart. So this is very important. At least remember this much. What else to be remembered regarding vitamin B12? In the deficiency of vitamin B12, it can cause macrocytic anemia, megaloblastic anemia, and you can get hypersegmented polymorphoneutrophils. There can be paresthesia because of neurological symptoms, and subacute combined degeneration, SACD. It is a degeneration of dorsal column. Again, one more MCQ. Dorsal column, lateral corticospinal tract, and spinocerebral tract due to abnormal myelin synthesis. Okay, methionine, again the same thing. So if there is not enough myelin synthesis, there will be neurological symptoms, and it can be associated with, I told you already, increased serum homocysteine level and methylmalonic acid, along with the secondary folate deficiency. Prolonged deficiency can cause irreversible nerve damage. So this is the minimum. So I always recommend to write every vitamin on one page about everything. So someone say B12, you must know, okay, cofactor for 2 point, deficiency causes this. So this much must be clear. What else need to be remembered regarding B12? It is found in animal products. Animal products synthesized only by intestinal microbiota. Now you can say, okay, it is synthesized even in vegetarians also because it is in the gut flora are there, they can form. But the problem is there, site of synthesis is distal to the site of absorption. Site of absorption is ileum. That is why in the question there was gastrectomy, and we can see over there that it can cause megaloblastic anemia. So site of absorption is B12. B12 is ileum, but synthesis is in the colon, gut bacteria. So although it is produced in the gut, it cannot be absorbed. Thus B12 must be consumed via animal product. It can be from milk also. So very large reserve pool is there. It is enough for several years. So normally B12 deficiency is very difficult to form until unless there is some sort of malabsorption like sprue enteritis by Diphyllobotrium latum, achlorhydria, bacterial overgrowth, or alcohol overuse. And there can be also lack of intrinsic factor like pernicious anemia. One more point to be highlighted over here is, what is pernicious anemia? It is an autoimmune disorder when antibodies are against what? Augmentic cell. That is why it cannot form intrinsic factor of Cassel. This is the reason B12 cannot be absorbed. So if B12 cannot be absorbed in pernicious anemia, they can be again megaloblastic. So megaloblastic anemia due to deficiency of intrinsic factor is called as pernicious anemia only when it is autoimmune in nature, antibody are found against beta cells. So this point is again very important. One more point to be highlighted over here, that sometimes there is use of some drug like metformin. Okay, it can also interfere in absorption of vitamin B12. Some diabetic person is taking metformin for last 4 or 5 years. Definitely if he is not taking B12 supplement, he can have B12 deficiency as metformin interferes with B12 absorption. So this much is needed from this topic, vitamin B12. It is a minimum. Even in more detail, at least the cycle you must know. See, homocysteine is converted into methionine by folate. But which folate? Okay, tetrahydrofolate, and this is methylated. So when this is converting, it will be methylated, and who is demethylating this folate? Vitamin B12. So vitamin B12 is required in demethylating. You just see the diagram. The methyl group is demethylated with the help of vitamin B12. Only then homocysteine can be converted into methionine. So if there is no B12, even we have folic acid, it is of no use. It is called as folate trap. It is folate trap. Although we have folate, but it is trapped. So until it is demethylated, it is of no use. So homocysteine will accumulate, it will increase, methionine will be less. So this is cycle which you must know. Now next question is your mechanical receptors with their function. Choose the right option. Pacinian corpuscles fast vibration, absolutely true. Ruffini sustained pressure, no, it is stretch. Meisner's stretch, no, it is a slow vibration. Merkel is slow vibration, no, it is 2-point discrimination, it is touch. Lot of things are there. So we have seen one question is definitely from sensory pathway. Very simple. Suppose someone is touching me here, okay, so am I feeling here? No. These are the receptors, Merkel, Meissner's, Pacinian, Ruffini, okay, and these will be carried by afferent. Afferent can be A delta, C for pain, A beta for touch, and they will go in the spinal cord. In the spinal cord, they will ascend upward via two pathway. One is called as dorsal pathway, other is called as anterolateral pathway, and they will go to the thalamus. Thalamus is the relay station. It is like antenna of your television. Okay, because of television, because of antenna, television is displaying something. Okay, so it is the antenna, it is a relay station of the cortex. Your cortex have sensory area that can feel the touch. So this pathway, one question definitely will come, one or two question will come. So first point is what? Receptor, then afferent, then ascending pathway, then thalamus, and then cortex. So this is the pathway. Now from receptor, again I am telling you, maximum questions are coming, and it is a very simple table. If you know this table, okay, you can solve maximum questions. So I have told you there are 4 receptors, but for pain we don't have receptor. For pain we have free nerve ending. Free nerve endings are for pain and temperature. You can see for pain and temperature we have free nerve ending, and for fast pain we have A delta, for slow pain we have C fiber, and this is very, very important because pain is a very crucial element. If there is some injury, it is a pain which is telling you that there is an injury. So there are no receptor, they are free nerve endings. Free nerve endings, they are simply voltage gated sodium channel. Okay, now rest 4 are the receptor, 2 are the corpuscle, 2 are the corpuscles. They are called as rapid adapting receptor. Rapid adapting, phasic receptor. This is again one more question. What are the rapid adapting receptor? Immediately they will adapt. You are wearing shirt and you will forget. You are wearing a specs and you will forget. Rapidly adapting receptor. Or phasic, they are not tonic. So they are called as phasic. So at the end, if you have corpuscles, they will be rapid adapting receptor. Okay. Now, Meissner's and Pacinian. Meissner's are for low frequency vibration. Pacinian is for high frequency vibration. Okay, very simple. There are 2 corpuscles. One is for low frequency, Meissner. Pacinian is a shape of onion. Pacinian has a shape of onion and sense vibration. High frequency vibration. Pacinian, onion, vibration. Okay, Meissner's for low frequency vibration, for fine touch, for texture. If you are feeling something like if you are feeling a cloth and you say this is a cotton or whatever, you are doing like this because it is phasic receptor. Okay, and for that what is involved? Meissner's are involved. Meissner's are involved. Now Merkel disc and Ruffini corpuscles. These are called as slow adapting receptor, or they are called as tonic receptor. You will not, for example, if your hand is on a knife, okay, you will not adapt. It is very crucial. Continuously keep on telling that there is a knife. So they are called as slow adapting receptor or tonic receptor. Slow adapting receptor or tonic. So Merkel disc and Ruffini are slow adapting receptor or tonic receptor, and Merkel disc is mainly for pressure, deep static touch, and Ruffini is for, you can see here, it is for pressure, deep static, and this is for stretch and joint angle movement. Okay, so at least minimum you must know this much about your neurocutaneous receptors. Okay. Next question, after right limb amputation, the patient is experiencing the phantom limb. What is the mechanism? Very simple question. We have discussed in the sensory law of physiology. There are so many laws, na? Bell-Megendi law. There is a projection law. This is projection law. Your brain is projecting even after limb amputation. Your cortex on the opposite side will project. Okay. So what will be the answer? Let me see. The projection of adjacent is the right limb. So projection will be on the left cortex. Okay, so what is the answer? Projection of adjacent fiber to overlap to the left sensory cortex. So this is simply called as projection law, law of projection. Brain will project it. Okay. A patient had sunburn, now takes bath, 40-degree water and feel pain. Now this is again a tricky question. Till date, they were simply asking about allodynia. Now you will say PYQs were not there. Of course, they will not ask you PYQ. But they will ask you same topic, because if topic is important, even if I have to make some question, I will make from important topics only, but I will change the frame of the question. I will change the question, but the topics will be same. So allodynia is a very important terminology. What is allodynia? When non-noxious, okay, or when non-painful stimuli is causing some pain, is called as allodynia. Now they have played a trick. What is the trick? There are two allodynia, this allodynia and this allodynia. Thermal receptor hyperalgesia, no, hyperalgesia is not the point. Innocuous thermal receptor allodynia and thermal receptor allodynia. Then again innocuous thermal receptor hyper, no, this is allodynia. Of course it is allodynia. Normally at 40 degree you are not feeling the pain, normally, but you are feeling the pain. So if I ask what is thermal receptor allodynia, if any temperature is causing me pain, okay, irrespective of that it should cause or not, it can be there. But when innocuous thermal receptor allodynia, normally 40 degrees Celsius should not cause pain, but it is causing me pain. So answer will be innocuous thermal receptor allodynia, not thermal receptor allodynia. When we are comparing two things, normally it should not cause at that temperature. When due to any temperature, when it is not causing pain but it is causing pain, it is called as thermal. But when I am saying, I am specifying the temperature here, and we know at this temperature there will be no pain if on taking the bath. So this is called as innocuous thermal receptor allodynia. Answer will be B. So even if you know the terminology, you should know more in detail about that. Allodynia, when non-painful stimulus is causing the pain, it is called as allodynia. A 50 years old female presented with dyspnea and chest pain. Which of the following proves that she has aortic stenosis rather than aortic regurgitation? So increase in myocardial oxygen consumption is seen with increased pressure work than volume. Of course, this is correct, true. Of course, in aortic stenosis, there will be stenosis of the aorta. So more, it have to contract more. Contraction will be more. So work done will be more. It is correct. Aortic stenosis causes reduced pressure. No, increased pressure. Workload has nothing to do. Of course, it has to do with the oxygen consumption. Increase in preload more than afterload. No. Increase in preload will be more in aortic regurgitation. When ventricles are contracting, blood will go back in the ventricle and preload will increase and diastolic volume will increase. So in aortic regurgitation, we can say preload is more. Preload is more, so in aortic regurgitation. So that is a wrong option. So correct option will be option number A. Taste absent in which taste bud? Filiform, foliate, fungiform, circumvallate. Now there were two questions regarding to the taste. So special senses nowadays, they are very important for NEET PG examination. Taste, olfaction, these all are very important at the level of receptors. That is why in my video lecture, if you see, I have made them new lectures because they were asked in much detail. So separate section is there for special senses in detail. Okay. So taste absent in which taste bud? These three are having taste bud. This is not having. So answer will be fili. So answer will be filiform. And this is from my notes only, from the video notes only, that 5,000 taste buds are present on papilla of dorsum of tongue. on the tongue also, soft palate also, epiglottis also, and pharynx also. Now you can see the tongue, the fungiform, the circumvallate, and the foliate, they all are having taste bud, not the filiform. Okay. Now again, question is from taste only. Sour taste is mediated by TRPP3. Some students are saying that TRPV3, it is for of course pain, and here option was TRPP3. Okay, I will show you the reference book also. Metabatropic receptor GPCR T1R1, GPCR T1R3. In my lecture, I have told you so many times, salt and sour, they are inotropic. Rest bitter, umami, sweet, they are metabotropic, G protein coupled receptor. So it is not metabotropic, it is not GPCR. Answer will be automatic. If you don't know, even if you don't know, you can answer this question, but you must know, because in the next examination definitely they will ask you more in detail, because they are already updated. You can see from boron, if you see the book, the boron, they have mentioned this TRPP3 channel. It is not V3. TRPP3 channel for star stimulus. This is the answer. But even you can rule out the answer, which is the correct answer. Now, salty is by ENaC. ENaC is epithelial sodium channel. It is the same ENaC where amyloride is working. It is the same ENaC whose gain of mutation causes which syndrome? Liddle syndrome. Gain of mutation of ENaC causes Liddle syndrome. We can see here. And these all are sweet, umami, and bitter. They are metabotropic receptor. They are metabotropic. They are G protein coupled receptor. Inotropic receptors will open channel and ion will go inside. In metabotropic receptor, it is not possible directly ion can go. So ligand will come, secondary messenger will be there. It will go in the nucleus and perform the appropriate action. So they work via secondary messenger. It can be IP3 DAG. It can be cyclic AMP, protein kinase A. It is a long discussion we have done already. So now taste salt by ENaC. It is again from my notes from DocTutorials. You can see stimulus is sodium. Stimulus is sodium. For SAR, ENaC and SCN, sometimes proton also block potassium efflux causing depolarization. So SCN channel, and please remember TRPP3. It is the latest update, please remember. And for sweet, remember for sweet is T1R2, T1R3, T1R2, T1R3. It is for sugar also, for saccharin also, act on gustadeucin and act by increasing IP3 and cyclic nucleotide. For bitter, it is a poison. So T2, remember T2, it is T1 to T2. Okay, like quinine, it will block potassium channel, strychnine. So this is for bitter. So this is the minimum which you must remember regarding taste. One more update. It is a recent update. It is a recent update that the SAR taste receptor was initially thought to involve a channel called as PKD, polycystic kidney disease 2L1, also known as TRPP3. This was asked in your examination, which belongs to TRP, transient receptor potential, same channel, family of ion channel. However, more recent research have highlighted the proton channel OTOP1, otopetrin 1 as a primary receptor responsible for detecting the SAR taste. So for next examination, you can update OTOP1. Please remember TRPP3 is also involved, but recent update is that OTOP1 is involved. This is regarding the SAR taste. Now this is again old question, very old question. When I take lectures in my medical college where I am professor, this is the first topic which I used to say. And whenever I go to take class anywhere, I don't know why they make mistake about the RMP. RMP is life. It is present in all the living cell, resting membrane potential. Whenever I ask who generate RMP, they say sodium potassium pump. Absolutely wrong. Sodium potassium pump can be responsible for maintenance of the RMP, but not generation. For generation of RMP, it is the potassium efflux. It is the potassium. See, inside we have most of the time potassium, and outside we have mainly sodium. Sodium is outside, but sodium cannot go inside. Why? Cells are not permeable normally at resting condition. Action potential different thing. In resting condition, normally sodium cannot go. Only when there is a stimulus, there is action potential, but potassium can go out. So what is the cause of RMP? Cause of RMP is selective. Cause of RMP is selective permeability of cell membrane. It is for mainly potassium, not for sodium. So it is a potassium efflux. Potassium keep on coming out for the Nash equilibrium, and inside will become negative. Inside will become what? Inside will become negative. So this will be negative. So what is negative? The negative charge inside the cell membrane is called as RMP. Very simple. The negative charge, if you put two electrode, one outside, one inside, okay, inside will be negative charge, it is called as RMP. It have to present in living cell. So RMP, physiologically RMP is life. That is why hyperkalemia, again, most important topic for your NEET PG and INCT, and hypokalemia, every year 1 or 2 questions are from this hyper and hypo. Why? RMP is because of potassium, and RMP is life. So if potassium become more or less, okay, it will affect the life, RMP. And that is why hyper and hypo both are dangerous. Both can stop the heart. It is a separate topic I have taken so many times. Okay, in hyperkalemia, if you see ECG, tall tented T wave. In hypo, there are inverted T wave. There are ECG finding. In hyperkalemia, we give what? Calcium gluconate to stabilize the membrane. Otherwise, RMP is disturbed. It is closer to the RMP now. Continuous stimulus will be there. That will cause accommodation. Heart will not respond. Heart will stop. So first treatment is always calcium gluconate. Second, we can give insulin because insulin causes influx of potassium. That is a whole different story. But the potassium, hyperkalemia, hypokalemia, this is all linked to RMP. We can only understand about the clinical feature of hyper and hypokalemia only if you know the detail of RMP, resting membrane potential. A man having difficulty in sleep during night, he has habit of drinking coffee before bedtime. What is the role of caffeine in wakefulness? Now every one of you, I must have marked it correct. It blocks adenosine action and cause wakefulness. Of course, this is the correct answer. It activates locus coeruleus and cause wakefulness. No, of course, this is for wakefulness only, but it is not blocked by caffeine. No role in maintaining wakefulness if there is 1 hour before sleep. No. Activate histamine release. No. Histamine is again important for wakefulness. That is why when we take antihistaminics, it causes what? Drowsiness. So, of course, these all are for wakefulness, but coffee, the role of coffee is not in that. Only it blocks adenosine action and cause wakefulness. Now, alcoholic gait nystagmus after RTA, which lobe of cerebellum is affected? Now, this is again a simple question. Again, I am telling you, cerebellum is a very important topic. Again, I am telling you, if you have taken the doctoral app, you must see. I have taken a 1 hour full lecture on cerebellum in more detail, including the clinical features, all the lobes, all the pathway, the histopathology and all, because this topic is again covering 2 or 3 questions every year. Okay, so until you know detail, for example, flocculonodal nerve have MLF pathway, medial longitudinal fasciculus pathway. If there is a lesion to this, only then they will cause nystagmus. Okay, so how it is happening, I have discussed that when you're moving your head like that, semicircular canal, utriculus oculus, they will send signal to the what? Vestibular nerve. It will pass upward to the 3rd nerve, 4th nerve, 6th nerve, and this pathway is called as MLF, medial longitudinal fasciculus. If that is involved by flocculonodal lobe, it is also called as archicerebellum. Physiologically, it is the oldest part of cerebellum, so it is called as archicerebellum. Neocerebellum, new one. Paleo is the older, and archi is the oldest, ancient, the oldest part of cerebellum, archicerebellum. Flocculonodal lobe is important for balance. Now identify the correct order of end plate potential at NM junction. Okay, calcium entry in axon terminal, acetylcholine release. Sodium channels open, action potential, calcium entry, action potential. Acetylcholine release, sodium channels open, action potential. Okay, so you can see here the action, calcium entry in axon, then acetylcholine release, then sodium will open, okay, and action potential will be muscle. So you know the diagram. You know the diagram from there, that action potential will come in the nerve terminal, and this action potential will cause opening of voltage gated calcium channel. Okay, voltage gated means what? At certain voltage only they will open. That is why they are called as voltage gated channels. So when action potential come down to the nerve, calcium entry will be there, and calcium is important for exocytosis of acetylcholine, and this acetylcholine will attach to the ligand gated acetylcholine channel in the muscle sarcolemma, you can see, and this will cause opening of the gate. Sodium will come inside, potassium will go outside, and this influx of sodium will cause action potential in the muscle. So this is called as, you can see here, excitation contraction coupling. So this is action potential was in the nerve, now it is in the muscle, so it is jumping. So it is called as neuromuscular junction transmission. It is called as transmission. So this is it for today's session. You are most welcome for any doubt. I will try to clear that. Thanks a lot.